In the last class, we have discussed thyroid gland and its function. Today, we will discuss some special aspects of thyroid which will be very helpful for your examination purpose and MCQ purposes. Thyroid cancers. Most common is papillary carcinoma, very slow growing. It appears as cold nodule. Follicular carcinoma is 10 to 15%, more aggressive than papillary carcinoma. Medullary thyroid carcinoma associated with MEN 2 syndrome. Anaplastic carcinoma, very rare but very aggressive, very poor prognosis. What are the risk factors? Radiation exposure, family history, genetic syndromes. Radiation exposure, last day also we have discussed that one CT scan of brain is almost equivalent to 400 chest X-ray in terms of radiation. So, whenever a young adult or a children is subjected to CT scan, so the chances of radiation hazards to the thyroid gland and in female ovary are very high. So, we must be very careful in advising or doing CT scan for young children and young adult. Presentation appears as thyroid nodule, lymphadenopathy in the neck, and sometimes it is very incidentally found during any operation. Most important diagnostic tool is ultrasound. What we will advise? Soft tissue neck, USG of soft tissue neck, or USG, soft tissue USG of thyroid, because you have to use a special probe to see the soft tissues. Fine needle aspiration cytology, and with this cytology we will do Bethesda classification and sometimes excisional surgery. We remove the thyroid gland and go for diagnosis. Treatment is mostly thyroidectomy, lymph node dissection if needed. The actual is thyroidectomy with all lymph nodes of the neck is cleared. Radiation, radioactive iodine ablation for differentiated thyroid cancers, when it is well differentiated, not gone outside the nodule, then only we can go for radioactive iodine therapy. Thyroxine suppression, particularly used for post-surgery to suppress the thyroid activity, and targeted therapy where that is already spreaded to the lung, bone or brain. Next we are coming to some other aspect. What is thyroxine? It is 3,5-tetraiodothyronine is the T4. Two tyrosine rings linked by one ether bond and 4 iodine atoms total, 2 on the inner ring, 2 on the outer ring. T3 is similar, only 5 does iodothyroid is not there. Same 3 iodine atoms, 2 at the inner ring, but outer ring has only 1. The key difference is the extra iodine on the outer ring compared to T3. T4 is the main hormone secreted by the thyroid gland, and T3 is the most biologically active form. T4 to T3 conversion happens in peripheral tissues by deiodinations of the T4. We have discussed vascular supply. I am given again very shortly. That is the most important here is thyroidea artery. It is incontinent but present in 10% of people. So those who are going on surgery, you have to be very careful. There is another third artery may be supplied there. Venous drainage, again it is important. I mentioned last day also. Here the middle thyroid vein drains lateral lobe, internal jugular vein, shortest and most prone to injury during surgery. Thyroid is the most vascular organ per gram of tissue. Another organ, any idea? Most vascular organ? Anterior pituitary lobe, which is why bleeding is a very major surgical risk. I am highlighting this only because you have to give importance to this. Gross idea is one thing, but to answer the MCQs particularly is very important. Thyroid chapter is very important for MCQs. Nerve supply. Sympathetic from superior medullary inferior cervical ganglia. Vasomotor control, regulates blood flow, no effect on hormone secretion. Parasympathetic via vagus nerve, minor role mostly vasomotor. Some important points, not to the gland but to the close and are at risk during thyroidectomy. Recurrent laryngeal nerve, which is a branch of vagus, runs in the tracheoesophageal groove posterior to thyroid, motor to all intrinsic laryngeal muscle except the cricothyroid. Here again it is a point of MCQ. What is, if there is injury, what happens? There is airway hoarseness or airway obstruction. Again, external branch of superior laryngeal nerve runs close to superior thyroid artery, motor to cricothyroid. Injury leads to loss of high pitch voice. There are some mnemonics for this artery, vein and nerve supply. I am not discussing here. The slide will be there. You go through this to keep it and remember it, discuss it always. Some key surgical or landmarks and danger zones. Superior pole, superior thyroid artery, external branch of superior laryngeal nerve close together. If we have to ligate the artery close to gland to avoid superior laryngeal nerve injury. So whenever there is circulation, we are doing thyroidectomy, we have to ligate the artery supply. So where we will ligate? We will ligate very close to the gland to avoid the superior laryngeal nerve injury. This prevents opera singer's nerve damage, loss of high pitch. Inferior pole or Berry's ligament. Recurrent laryngeal nerve passes behind and between the branches of inferior thyroid artery here. Ligate inferior thyroid artery branches individually away from the gland to avoid adrenal nerve injury. So, for superior thyroid artery, where we will ligate? near to gland, and for inferior thyroid artery, away from the gland. Varus ligament connects thyroid to trachea at cricoid level. RLN most vulnerable here because it's fixed and close to the capsule. So important note, this Berry's node and tubercle of Zuckercandle tricks, those are the two landmark surgeons actually used to find the RLN. So these are the point. I am highlighting this only because I am not a surgeon. I cannot explain the tricks, but keep it in mind. Now we will come to the thyroid hormone carrier, another short note. What are T3 and T4 both are lipophilic. 90% circulates bound to carrier proteins. Only the free fraction is active. Main thyroid hormone carriers in the blood are thyroxine binding globulin TBG, 70% binds of T4 and 80% of T3. Highest affinity but lowest concentration. Made in liver, levels increase in pregnancy, high estrogen level, hepatitis, level decreases in androgens, nephrotic syndrome, and liver disease when there is a loss of protein synthesis. Transethyretin, tyrosine binding preallulin, 10 to 15% of T4, but very little of T3. Lower affinity but higher capacity. Also transport vitamin A via retinol binding protein. Another MCQ. Albumin binds to 10 to 20% of T3 and T4. Lowest affinity but highest concentration. Act as a large low affinity buffer. And Phe hormone is only 0.03% T4 and 0.3% of T3 is free. These free fractions enter cells and is biological active. And this is what lab tests as free T3 and free T4. What is the importance? I am coming later. Clinical point. Total T4 and T3 levels change if the binding proteins change, but free hormone stays normal. Example, in pregnancy, high TBG, so there will be total T4 increase, but free T4 stays normal and patient is euthyroid. Drug interactions. There are certain drugs which dislodge thyroid hormones from the protein binding sites. Drugs that displace T4, T3 from binding proteins, heparin, salicylates, furosemide, phenytoin carbamazepine, and NSAIDs like phenylclophenac, mefenamic acid, these sort of medications. So when they are releasing the hormones from the site, so there may be a abnormal high levels of T3, T4, and that may cause some adverse effect. So these we have to keep in mind when the patient is being given a thyroid patient. We are desired patients that this patient is having a thyroid excess, and we have given him a salicylates or furosemide. So that particular release of T4 and T3 may adversely affect his cardiac functions and all that. Key lab pattern with displacement. When there is displacement, there will be immediate increase in the free T4, but total T4 will be normal. After equilibration, hours to days, free T4 will normalize. And throughout the time, TSH will remain normal because hypothalamus and pituitary sense free hormone only. This is the most important line. Again, a MCQ that hypothalamus pituitary sends only the free hormone, not the total T4 or T3. And it returns to normal quickly. Why this matters clinically? When we are given a lab investigations, the patient is on salicylates or in other conditions in pregnancy. So, and given carbamazepine taken, so that may leads to some abnormal report. Euthyroid sick patients on ICU medications. High dose of furosemide heparin can make free T4 look high, but patient is not thyrotoxic. We have to check the TSH. It will be either high or normal in sick euthyroid. And sometimes starting or stopping these drugs can alter the thyroid labs without changing the true thyroid status. So, this drug carrier or a carrier of thyroid hormone and their effects in the drug interactions is very important in these aspects. Another is sick Euthyroid Syndrome, that is non-thyroidal illness syndrome. This is, patient is sick and we are getting some abnormal reports, but the patient's thyroid function is absolutely normal. This is the basic concept. So, thyroid lab changes in the sick patients with normal thyroid gland function. Body adapts to reduce the energy used during illness. This is called sick Euthyroid Syndrome. What is the classic pattern of by 3 types? Mild illness, where there will be low T3 because there is a reduction of the 5-dehydrogenase activity. So, less T3 to T4 to T3 conversion. Here one important thing, this reverse T3. T4 dehydrogenases in 2 conditions. One is normal T3 and another is RT3, where the 5 is on the other persons, isomerism. So, this reverse T3 is high and T3, TSH, T4 and total T4 will be normal. And in moderate severe illness, both T3 and T4 will be reduced because there is less TBG formation or displacement from the binding proteins. Free T4 usually normal or low normal, but can be low on some assays. Again here TSH is normal because not high like hypothyroidism. Recovery phase, TSH may transiently rise to 10 to 15 for a few days, then all lab normalize as illness resolves. So, sick Euthyroid syndrome perplex those who are working in ICU particularly, and for prolonged medicine ward patient, the patient is usually euthyroid stated, admitted during some other conditions, but after some days we find that there is an abnormality in the thyroid reports. So, whether this is a normal TSH functions abnormality or a sick euthyroid, we have to determine. Why it happens? Cytokines, interleukin 6, TNF alpha, cortisol, malnutrition, suppressed TRH, TSH and dehydrogenases. Adaptive response to decrease the metabolic rate during the stress. Here are some key lab clues. TSH remains normal or low despite low T3, T4. RT3 is high, where in normal hypothyroidism, RT3 is low, because in both cases there is reductions of the thyroid hormone. Clinical context, patient is sick in ICU, post-op, sepsis, starvation and myocardial infections, and patient will not have any goiter or normal thyroid examinations will be found in lab examinations. Management, do not treat with levothyroxine. Multiple trials show no benefit. Treat the underlying illness. Thyroid labs normalize in 6 to 8 weeks after recovery. Exception is TSH is more than 20 or free T4 is very low and patient has symptoms, then we should consider it as a true hypothyroidism. Common triggers: sepsis, burns, trauma, surgery, MI, renal failure, liver disease, decay, starvations, and any critical illness. It is very common, we found in the ICU, very common. Now the primary versus, and accordingly there is combinations of the report. We have to consider, think, read it repeatedly to get it accustomed that when, and most effective thing is that you discuss. You see any when you are going to the clinical classes, check the reports, not only the patient. You just check. Sometimes this we miss. Sometimes we miss. We only focus our notice to the TSS level. Just check with the TSS level if the T3 and T4 is also normal or abnormal, and discuss. Bring to the notice or your teacher's notice, sir, why it is. Then these discussions will increase your adaptability towards the thyroid problems. I am not mentioning, so it will be there in the slides. Go and discussing it. Main thing I am again telling, for hypothyroidism, TSH is the discriminator between primary and secondary. We are not going to see the T3 and T4. If TSH is high or if TSH is normal, even when there is, in hypothyroidism, when there is a TSH is less than normal, then we will look into T3, T4 or FT3, FT4 to diagnose it as a hyperthyroidectomy. But for hypothyroidism, only one thing, keep it in mind, TSH is the main thing to discriminate. Also don't miss the adrenal insufficiency. In secondary hypothyroidism, ACTH may also be low. When there is a pituitary adenoma, which is suppressing the pituitary gland, it also suppresses the other gland. ACTH also suppressed. So there may be adrenal insufficiency also. Now, if there is adrenal insufficiency, you are looking into, there is a, always check morning cortisol before starting levothyroxine. Because if it is due to hypopituitarism related or the secondary hypothyroidism, if you start L-troxin without correcting the cortisol level, it will be a detrimental to the patient's condition. You have to replace the cortisol also. Treatment dose differs. In secondary needs lower levothyroxine dose because you are just replacing, not overcoming TSH drive. And where I am discussing this subclinical hypothyroidism. This is a very subtle thing. If we keep a clear mind, we will see this sort of report in the OPD frequently. TSH is elevated, but FT3 and FT4 are still normal. Patient often has no or mild symptoms. Incidentally, we are given for investigations and find that TSH is high. How it fits with primary versus secondary? Subclinical hypothyroidism, here TSH will be mildly elevated, 4.5 to 10, rarely more than 10. High in overt primary hypothyroidism, and secondary hypothyroidism, it will be low or inappropriately low. In subclinical, FT4 will be normal. In primary hypothyroidism, it is low, and secondary hypothyroidism, it will be low. Site of defect, thyroid gland starting to fail. Thyroid gland is failed in primary hypothyroidism, and in secondary hypothyroidism, there will be a problem in the pituitary. Here symptoms is none or mild fatigue, In primary, there will be classical hypothyroid symptoms and hypothyroid or other pituitary deficiencies. In subclinical hypothyroidism, we will consider it is a problem of the thyroid gland by doing the TPO antibodies. If it is positive, then we will see this is a going to be a primary hypothyroidism. But now, the clinically, it is by lab, it is now not that thing serious concern. But in a long term, it will change over to primary hypothyroidism by checking the anti-TPO. And anti-TPO antibodies will be high in the Hashimoto's. Often in secondary hypothyroidism, it may be negative. I am sorry the presentations, but I am not very keen on doing the slides. So these are actually a graphic, the tabulation form. When I converted into slide, so this I cannot represent it. If you possible, I've told someone whom to make it clear representable. In early primary hypothyroidism, the thyroid is struggling, so pituitary increased TSH to keep free T4 normal. So it is a compensated hypothyroidism. Progression leaks 2 to 5% per year progress to overt primary hypothyroidism. TPO positive means it will go rapidly. When to treat? Not automatic. Guidelines is to treat if TSH is more than 10, TPO positive, symptoms present, pregnancy or trying to conceive, goiter, dyslipidemia, age less than 65. More than 65, just find out a question. It's more than 65, say 60, 70 years male patients came with TSH 10, normal T3, normal T4. What will you do? Question will be like this, because 65, less than 65, we will not treat. Observed TSH 4 to 5, no symptoms, TPO negative, age more than 65, recheck 6 to 12 weeks, because 30% normalizes spontaneously. Why secondary cannot be subclinical? By definition, secondary has low T4. If pituitary fails, it cannot raise TSH. So you skip straight from normal to over T4. There is no subclinical secondary stage. So subclinical stage is only in primary. The quick diagnostic flow, check TSH, free T4, high TSH, low free T4, high TSH, normal free T4, subclinical, low and normal TSH, low free T4, secondary or tertiary or sick euthyroid. Treatment targets for each type. TSH goal differs for primary and secondary. Most difficult part to treat and when to treat. When and what is the level of TSH we want to maintain in different clinical categories. So, say in pregnancy, what is the most important thing to check? That is the free T3, free T4 and TSH. Why free T3 and T4? In pregnancy, thyroglobulin is increased, so total T4 may be increased, but the effective free T3 and T4 will be normal. So we will check the FT3 and FT4 and TSH. If TSH, our aim is to maintain, in the last day we have maintained the rate, we will try to maintain it at around 2.5. So, or those who are planning to go for pregnancy, we will ask to maintain at the level of 2.5. So, how to start? Again, I have told you to start with according to body weight, you adjust the dose and start with 50% and increase very slowly in every 15 to 2 to 3 weeks interval to gradually adapt the system. Goal is 0.5 to 4 for most adults. In younger patients, 1 to 2.5. Levothyroxine dose is 1.6 microgram per kg per day average. Start with 25 to 50 microgram elderly, full dose in young adult. Check TSH 6 to 8 weeks after any dose change. Once stable every 6 to 12 months. Free T4 should also be normalized as TSH is the main target. Again, we have to maintain for more than elderly, target TSH is 4 to 6. Higher TSH is normal with age and aggressive treatment will lead to atrial fibrillation. Thyrotoxicosis is one of the important factors of atrial fibrillations in the elderly. Pregnancy, target TSH trimester specific, first trimester less than 2.5, second less than 3 and third 3 to 5. History of thyroid cancer targets TSH less than 0.1 if high risk to suppress any remnant tissue. Again, this is a very important catch. Thyroid cancer patients, what is the target? Secondary or tertiary hypothyroidism, free T4 is a concern, not TSH. Free T4 in the upper normal range. Pituitary is broken, so TSH is unreliable. It will stay low or normal even when under replaced. Usually lower than primary, that is 0.1, 1 to 1.2 microgram. And we will check free T4 6 to 8 weeks after doses. Also important, I have mentioned, check the cortisol or ACTH before starting T4. If secondary adrenal insufficiency coexists, replace steroid first before starting thyroid. Subclinical, target TSH if you decide to treat. So now, general treatment principle for all types. Take levothyroxines, empty stomach, 30 to 60 minutes before food or coffee, 4 hours away from iron, calcium, antacids and PPI. What is PPI? Proton pump inhibitors. Why this is? It is a very important because all these iron, calcium, antacids, PPI alters the absorption of the thyroxine. Same brand, bioequivalence is perfect, so stick to one manufacturer. So when a patient is being maintained with some particular brand, you maintain with that. If you change due to non-availability or availability of the biosimilar, then you have to readjust again to check frequently whether it is giving the same result or not. Over replacement risk, atrial fibrillation, osteoporosis, anxiety. TSH less than 0.1 increases risk. For primary hypothyroidism, where TSH is the target, take 6 to 8 weeks for TSH to recuperate after each change. Change by 12.5 to 25 microgram increments. Avoid big jumps unless TSH is wildly off. Wait 6 to 8 weeks before rechecking TSH. T4 has a 7-day half-life. Target TSH 4.5 to 4 microunit per liter for the most adults. Here is another important thing, that is T4 has a 7-day half-life. And the medicines we are giving, what is that? T3 or T4? T4. So there is a scope of once a week therapy. Some particular pattern is also maintained. Some gives it alternate day. Some forgets to take the daily doses. they can be given in the next day, no problem. But the dose has to be adjusted according to bioavailability of that particular dose schedule. Again, there is a chart. You can calculate how quickly you can do it. Some special situations where you are getting poor compliance. TSH very high, free T4 normal or high, missed doses, then took several before TAC, counsel, don't just increase. Earlier cardiac change by 12.5, overdosement is high risk. Pregnancy increase the dose by 30% as soon as pregnant. TSH targets are tighter. Weight change. Again, here is 1 microgram per kg. If patient gains weight or lose or more than 10% of body weight, expect dose change. New medications starting iron, calcium, PPI, estrogen. TSH will rise, recheck in after 6 to 8 weeks. So you are a patient on hypothyroid, you are starting with iron tablets. You have to specifically maintain that you take this iron tablet at least 4 to 6 hours apart from taking the thyroid medications. So these small things matters. One important thing we have to keep it in mind that the normal range of thyroid hormone TSH level, what we want to maintain is very narrow. It's a 0.3 to 0.4, 0.5 to 5. So within this small range, we have to keep it in. So minor change in the thyroxine level in the blood will alter the TSH level and alter the efficacy and risk factors in several ways. So this is a very important change very slowly, and small advice will give a good compliance of the patients. The patient will not suffer. Some patients complain that whenever I am taking the medications thyroid, I am having some suffocations, I am having some palpitations. That means, but we are checking the report, the TSH is still high. On inquiry, we found that the particular patient is taking antacid early morning, empty stomach. They are taking PPI also, they are taking calcium also, and they are taking thyroid hormone simultaneously. And they are taking a cup of coffee also. So, you have told me to empty stomach, coffee I have taken. You have to be very careful to give advice of thyroid, because small dose irregularities may lead to a certain complications, serious complications. I know particular aspects are very boring, and to keep it in mind is very, very tough. The special situations I have tried to mention, I have given special importance, so I have taken a repeat of discussions on this. Use these points, see it, where it is the tabulation form which is not represented very well here, please make it a table and put it there and use it. Thank you.